I started diving into hormone replacement therapy for women before menopause, and that's testosterone. And what does that lead to? Which is bone density and muscle tone and pain relief and a sex drive and clitoral engorgement and innervation and all of these things. Women experience night sweats, no libido, delayed or unobtainable orgasms. It gets very ugly at the gym when total testosterone in women falls below 30 or free testosterone falls below 5. That is where the more she works out, the less fit she gets.
Welcome to the Hot Flash Health Podcast, where we're dishing out unfiltered truths about menopause with a side of sass and a sprinkle of grass.
Get ready to dive into the wild world of hot flashes, mood swings, and all of the other joys of being a queenager.
This ain't your grandma's podcast. No, we are here to talk our bodies, our fears, our passions, our desires, all while navigating this wild roller coaster ride of menopause.
So grab a glass of wine,
Or three.
kick back, relax, and let's enjoy this hot flash wave together.
I'm Courtney Mamusha, and alongside me is my fabulous co-host, Dawn Fable.
We're just two outspoken broads who like to call it how it is.
Now, without further ado, let's kick off today's episode.
Welcome, ladies, back to the Hot Flash Health Podcast, where we are just real women who are trying to find real solutions. Welcome to the conversation we've all been waiting for: menopause, hormones, and taking back your damn body. For too long, including us, women in their 40s, 50s, and 60s have been totally dismissed, ignored, and told just to deal with it. Hot flashes, brain fog, weight gain, low libido, yes, they're real, and yes, they matter. Today, we are chatting with someone who refuses to let women be invisible. She's a clinician, she's an educator, she's a trailblazer in functional medicine, using bioidentical hormones and smart medical weight loss to help women feel like themselves, to be only stronger, sharper, and unapologetic. This is the kind of conversation with a guest who sees you, hears you, and gives you the tools to take control of your health. And trust me, ladies, I was sitting in the beautiful office of Miss Kimberly Cunningham yesterday, and for the first time in my life, I felt seen, I felt heard, and I feel optimistic of this beautiful path forward. So meet Kimberly Cunningham. Kimberly Cunningham is a board-certified nurse practitioner and founder of Cunningham Clinic, who specializes in hormone replacement therapy, HRT as many of us have heard it, and medical weight loss, amongst many other things. With 20 plus years in healthcare, from emergency rooms to healthy aging, she's helped countless women, including myself, reclaim energy, balance, and vitality. Her passion for hormones is personal. After a catastrophic injury left her immobile, Kimberly fully recovered using bioidentical HRT, amongst other things. Now she trains other providers, combines HRT with targeted medical weight loss, and guides women to optimize metabolism, muscle tone, and long-term health. She is also the author of the #1 new release on Amazon, Great Sex Never Gets Old: Health, Hormones, and Having It All After 40. Her mission, you might ask, to end the dismissal of midlife women, showing that aging is not a decline, and prove that menopause is the perfect time to thrive. Welcome, Kimberly. You look beautiful as always.
Thank you for having me.
Oh my gosh. Of course, you are a force to be reckoned with, and I couldn't have spent enough time with you. So we invited Kimberly to dig in, and of course, I'm going to be sharing my personal experience throughout the deal. So let's get started.
All right. So women in menopause obviously feel very invisible sometimes, dismissed by doctors and even by themselves, questioning what's going on with our bodies. Why has this been allowed to happen for so long? Like, what is happening? Why can't we get answers?
Well, it's not just menopause. Actually, if you look at the National Institutes of Health has many publications on both racial and gender-based bias. And men, particularly white men, will walk into an exam room believed before they even open their mouths. Women are not. Women and people of color have to prove that they're there for a reason, and that's a valid reason. And this bias has existed for probably centuries. And this bias in the United States is very prevalent. And unfortunately, it's also fueling AI because AI is very good it's very good at learning. And so AI is learning how clinicians speak, diagnose, treat, and it is learning the implicit biases in the United States. So we have to be very careful as we move forward that we don't take these biases into the next generation of healthcare, which is going to be AI driven. It really will be. Whether we like it or not, that's where the world is going, at least for a while. So how it's been allowed, I don't know, because this also happens from women providers. So it's not just male providers who have gender and racial based biases. It's all providers. And some of the theories go back to it's the medical school vernacular. It's the how do we teach healthcare in nursing school, in medical school, in these programs. And then how do we continue that bias in continuing medical education? And now we have it in our AI models, and it's already been found in the AI models. So knowing that it exists, even though we can't change it, is still really powerful. All knowledge is power. And so if you know that when you walk into your healthcare provider's office, that you might not be believed just because you own a vagina, that means you should be armed with better language to get that provider to pay attention to you. Or know when it's time to punt and go to another provider. So these are options that we can get through today. I don't know.
And women, whoever isn't using AI, you can actually come armed with a list of questions for your provider, right? So use AI in your.
Yes, absolutely. So things that you want to have are, when did this go wrong? When did you start feeling bad? What do you want to do about it? When is it not acceptable to say, this is your 40s, get used to it? Which is what doctors will often say to patients. Well, what did you expect your second half to look like? Well, I expect it to be working. I expect it to be functional. And understanding that when you look at OBGYN residency programs in the United States, less than 1/3 actually have perimenopause and postmenopause hormone care in the entirety of their program. So the doctors who are supposed to be the experts of women's reproductive health, which yes, includes having a baby, but also includes the rest of the time you own the hardware, right? They only 1/3 spend any time at all in perimenopause, menopause, and postmenopause care. And the residency programs that spend any time on it spend less than 7 hours. So those are abysmal numbers.
Yeah.
So I've been doing this for a decade, and I teach at 2 universities, and I teach for a professional medical education company. So I try to teach as many as I can because I can't possibly see everybody. But we are playing catch up because still today, even with all of the residents begging for more hormone education, less than 1/3, less than 7 hours.
I mean, those are just dismal statistics. It is so sad. And you wonder why we as females are being dismissed.
Or not asked the questions.
You know, Kimberly, there were so many reasons that Courtney and I were drawn to you. And one of them was your personal story. And you have this incredible, vulnerable story of something that happened to you years ago that left you immobile, 10 surgeries. And you really leaned into that to empower other women and utilizing HRT to regain your strength amongst many other things. And that's what makes it so special, right? Is you're using a personal story or struggle and helping empower other women. Can you share with us a little bit about just that story in itself?
So like most of us, you have your plan and then life says, hold my beer. And your plan goes somewhere else very quickly. So I'm an athlete. I've always been an athlete. I danced professionally. I danced for the University of Florida. And then I did triathlons and I taught fitness competitors and did choreography work. So I've always been in the gym, in the studio, on the race course. And about halfway through my second pregnancy, my pelvis spontaneously failed. So I went from a top 10 finish in a triathlon to a year and a half later. I couldn't walk. I couldn't drive a car. I couldn't sneeze. I couldn't do anything. I had to just grow a baby. He's fine, by the way. He just turned 15. Got his permit. So watch out, world.
Your son and my daughter.
Right. So nothing was working. I couldn't get better. I had to have him early. He was fat and happy, but a preemie, and he's fine. And we tried shots, and that didn't work. And then we tried surgeries, and then more surgeries, and hardware in and hardware out, and nothing worked. Now, I was a triathlete. I don't care about hard, I care about results. So if you want to get from here to there, and most women know how to do this, you just break down the steps. Some of them are going to be rougher than others. Let's go. Women just get things done. There was no go. I couldn't PT my way back. I couldn't do physical therapy enough to get back. I couldn't go through enough surgeries to get back. I couldn't eat right. There was nothing I could do to get out of this wheelchair. And I was barely on a walker and barely on a cane for short distances, but anything longer, I had to have a wheelchair or a scooter. And I went to a lab review class, sat next to the cute purse way up on the left. I thought, oh, she'll be interesting. Got a cup of coffee and walkered my way up there. And it turned out to be this woman I'd gone to graduate school with years ago. And when she knew me, I was auditioning for the Broncos cheerleaders and made the top 50. That was super fun. Thank God they didn't pick me because I didn't have time to do it, but it was a really fun thing to audition for. And she knew me then, and she sees me on this walker with no muscle tone, and I look awful. She said, what happened to you? So we get to talking on a break, and she said, why aren't you on testosterone? And I said, well, I'm only in my early 40s. I'm not in menopause. And she said, no, now. I got my blood test levels, and I had no testosterone. So clearly I used to make testosterone, but then my injury halfway through my pregnancy, which turns out was a collection of, I have a connective tissue disorder I didn't know I had. I have a congenital misshapen pelvis I didn't know I had, and my body made too much relaxin in that pregnancy. It was the trifecta of doom that never happens, but it happened to me. And I didn't know anything about testosterone therapy for premenopausal women. And I don't make less than 100% on a test because I'm the nerdiest nerd you're ever going to meet. I want to read everything. I want to know everything. I'm neurotic about all of the bits and pieces and how does this work and how does this affect that. And I always want to make sure that everything I'm doing is for improvement and I'm not trading one set of side effects for another. And I'd never even heard of this because in my program, we didn't talk about it either. And that was at the University of Colorado. And so I started diving into hormone replacement therapy for women before menopause, and that's testosterone. And what does that lead to? Which is bone density and muscle tone and pain relief and a sex drive and clitoral engorgement and innervation and all of these things. And when mine was at 0, that's why none of these surgeries were ever going to work. That's why the hardware didn't set into the bone, because that takes testosterone. And I didn't have any. So I got my first round of pellets because I chose pellets as a modality for getting testosterone back in my body. Within 3 weeks, my pain was gone. Within 3 more weeks, muscle started coming back. And I had quit going to physical therapy because it just hurt and it wasn't doing any good. Like I was going to book club and drinking wine. I had enough. And all of a sudden, within 2 months, I was back. And I thought, okay, this is really exciting. And I thought, I need to do something about this because if I didn't know about this, nobody I went to school with knows about this. Nobody who went to the University of Colorado knows about this. Nobody who went to any program knows about this. And there are millions and millions and millions of women my age in this country that need this care. So I opened a practice and it's been 10 years.
I mean, I love that. And I love too, I think there's so much misinformation about testosterone, right? I mean, I think we all grew up knowing like testosterone is for men and progesterone and estrogen is for women. So it's not just a male hormone. I mean, she is a living, walking testament that testosterone is needed for us women to grow healthy muscles and get energy, right? And I'm just...
Well, people talking about this. You know, I play very mediocre 2.5 tennis, and we have had 2 or 3 women on our team who are our ages, you know, mid 40s, mid 50s, who are getting knee replacements and getting hip replacements and really struggling with sort of the outcome or on the other side. And so the fact that if we had more testosterone in our body, because obviously that decreases with time, those recoveries and outcomes could be that much stronger. And I would venture to say, you're the expert, Kimberly, but is that why so many women, and as they age, you know, are falling down and breaking their hips and things like that?
So you need bone density from testosterone and estrogen. You can get there from testosterone alone. I have lots of women who, for whatever reason, can't have estrogen, so they just get testosterone as they age. But women's testosterone falls 15 years before menopause. So that's age 35, which is why a lot of the fitness trends are get your muscles in before age 35 because you're going to start losing them. Well, not if you replace the testosterone when it falls. Men get to hold on to their testosterone about 15 years longer. They start to lose their testosterone around age 50. In this country, it's actually a little bit earlier, but worldwide, it's about age 50. And so that's also believed why men get to look better a little bit longer. because they have their hormones a little longer. Men also need estrogen. When men's testosterone falls, their estrogen subsequently falls, and there goes their mood and their bone density. So men get osteoporosis as well, and they're going to fall and break a hip as well. They'll just do it about 15 years later than the females will. We want to replace hormones in men and women as they fall so that their bodies don't age out underneath them before they're ready.
Yeah, well, good to know. I mean, I think so many people too are nervous about hormone replacement therapy. And I know, Dawn, you just got this procedure, so you can talk a little bit about it. But what's like one of the biggest myths that you can put to bed right now with having women get hormone replacement therapy?
So there was a study published in 2001, or it was rather stopped in 2001. It was one arm of the Women's Health Initiative. So the WHI was the National Institutes of Health funded longitudinal study on women, because women aren't studied. We aren't even studied for drug safety. So most drug safety trials are done on 18 to 25-year-old white males. So we don't even know if the drugs work for women or if they're safe for women. So there's so much about us that aren't cared for well in the United States or even worldwide. And so the WHI was trying to fix that. Let's study women. Let's see what happens. And so one of the arms of this study was looking at hormone replacement therapy for women. None of it was testosterone. It was either pregnant horse estrogen, which is not human identical or bioidentical, or pregnant horse estrogen with progestin, a synthetic progesterone, in women who still had a uterus. The study was inherently flawed. In the Prem-Pro, which is Premarin, which is pregnant horse estrogen, with progestin, which is medroxyprogesterone acetate, a synthetic. And that arm of the study, they picked older women who had never had HRT, who were at high risk for breast cancer. And guess what they found? A slight increased risk of breast cancer in those women.
Breast cancer, yeah.
Because when you take women who are at risk of breast cancer and you study them, they are probably going to get breast cancer. So at this tiny little uptick in breast cancer in that side of this arm of the study it was turned into Chicken Little, the sky is falling. Oh my God, you can't give women hormones because they're going to get breast cancer. So it was the wrong group. They also used the wrong inferential statistics, used the wrong statistical model. But let's say, just for giggles, that was an accurate finding. Let's just say, okay, 2 in 1,000 women are going to get breast cancer if you give them hormones. Let's just say that's accurate, because it's not. And I have tons of other studies to prove that. You can still prove a reduction in fracture, a massive reduction in heart disease, which is the number one killer of women. So what we die from, hormone replacement therapy prevents a massive reduction in the risk of metabolic disorders, including type 2 diabetes, which is how you get Alzheimer's, a disease that is way more prevalent in women than men, even if you correct for the fact that we live longer. So all of the other things that are going to come and kill us, hormone replacement therapy, even in that study, made better. Now, when you actually correct for the fact that they studied the wrong group and they used the wrong statistics, we have buckets of other studies, lots of data showing that if you replace estrogen in women, as soon as they lose it, you reduce Alzheimer's, you reduce heart disease, you reduce fractures, you reduce, again, the things that we feel, hot flashes, vaginal dryness, sexual dysfunction, but you also reduce the risk of breast cancer. So every other study on the planet outside of that one shows estrogen is breast protective, not cancer causing. And if you go back to pregnancy, this makes sense. So by the way, when the WHI came out, most of us said that doesn't make any sense, because in a pregnancy, a woman's estrogen goes into the thousands, as high as 4,000. When she ovulates, it's about 150 to 300 on a blood test. So if you're hitting 4,000 sustained estrogen level in your blood during a pregnancy, you would birth a breast cancer tumor every time you birthed a baby, because if one causes the other, that's what you would see, right? In fact, the more pregnancies a woman has, the lower her risk of breast cancer.
You're never getting breast cancer.
Knock on wood, sister, knock on wood.
So it's breast protective. So estrogen is breast protective. By the way, in the WHI, none of those women got testosterone. We need our testosterone for muscles so we don't trip and fall like a tree. We need our testosterone for clitoral engorgement and for libido, and also for bone density and for cancer protection, and is all testosterone as well. So it was a flawed study. Chuck it out the window. You can have your hormones, and you need your hormones so that you age in a body that stays healthy.
But the aftermath of that study has been so disparaging. I mean, this was on the cover of Time magazine. This was on every Dateline, every news program you could imagine. And the aftermath of women still to this day, including myself until I saw you, being so fearful of getting this and doctors being so afraid to recommend this, not only because of the lack of knowledge, but because of the litigious society that we live in these days. It's just such a shame.
Well, we are more than 2 years post retraction of the study by the authors. And fear sells. So, of course, Cover Time magazine, we're causing breast cancer in women, but good healthcare doesn't sell. So there's no Time magazine cover that I've seen since the retraction over 2 years ago, where all of the authors, except for one, said, oops, sorry, we were wrong.
Whoops.
Yeah. Kimberly, I've learned so much from you, not only in my personal experience and, getting my testosterone pellets, but, you really spending time with me. And what I've learned that HRT isn't just estrogen, right? It's testosterone, it's thyroid, it's vitamin D, it's so much more. When I saw you truly looked at the entire comprehensive picture of all of my blood work outside of just my hormones. And we talked a lot about why it's so critical to tune up what's happening in your entire body instead of focusing on just one piece. And what you shared with me in, so many different parts of my body weren't operating at an optimal level, and how that really impacted what I was seeing, right? I couldn't quite pinpoint it other than feeling off, sort of losing my joy in most things, not being able to lose weight if I tried, feeling absolutely exhausted. And what you said to me really struck. You said, Dawn, you must be a very, very tenacious person, because the fact that you have been surviving with the way that your blood work was showing, which by the way was showing within range, is a miracle. And I think that's how most women are feeling. We just are tenacious and we're powering through despite feeling off. So share with me and our audience, of course, as to your approach, comprehensive, how hormones play into thyroid and how all of the things sort of work together and what you do to solve that.
So a couple of things. When it comes to labs, the United States recommended annual labs is woefully inadequate. So we'll just start there. So if you get 5 labs from your primary care provider once a year and they say, look, you're fine if you thought about cutting carbs, that's not enough information. So we need more information. And I always like to say, I didn't go to magic school. I have to measure. So I need more information. And the other thing about labs is you get a range. So when you see your lab printout, there's the name of the lab, what they found in your blood, and then there's this range off to the right. That range is what is expected. So if you are a 60-year-old woman, that range is what we expect to find in a 60-year-old woman. That doesn't mean it's healthy. And by the way, I'm in Denver. This is Denver. I use LabCorp here in Denver. So for labs to stay certified, they have to compare their results with another certified lab. They'll certify off of each other periodically. It's just how labs work. You want to make sure that their machines are accurate and they're reliable. And so here, LabCorp in Denver certifies off of Denver Health, which is our community hospital. So if I'm a 60-year-old woman and they say that's what I expected to find as compared to a 60-year-old woman who's in the hospital at the community hospital, that's not healthy. That is not optimal. That's just, you're not a surprise because you look like an old person, or if you're 70, or if you're 80, or if you're 90. And in this country, in the United States, we lose our hormones sooner than our European counterparts by almost 10 years. So that's environmental stressors. So whether that's the endocrine disruptors or the lack of diindolylmethane in our broccoli and different superfood ingredients that have been leached out of our vegetables, I have no idea. But we lose our hormones about 10 years earlier than our European counterparts. So I really don't want to test, and I'll be 55 in January. I don't want to test like a 55-year-old female at the community hospital. I want to test like a 30-year-old female, a version of myself. So when we look at the labs and we look at the range, a lot of times it'll say normal and abnormal. That means nothing. What is a healthy 30-year-old female, if we're looking at a woman, or a male, if we're looking at a man? What's their range? And then do we want to be an A student, or do we want to be a D student or an F student? We want to be an A student. So we want to be at the optimal end of that range. So that's when you start looking at labs through a functional medicine lens, you just really get this lovely paradigm shift. And functional medicine is where we look at, are the parts working? If they're not working, where did it come off the rails, and can we give it back to that person without just naming it, medicating it, and I'll see you in a year. So functional medicine is it working? So when you look at labs, first of all, it's not the range to the right. It's the what is a healthy 30-year-old version of that. So you need to go to somebody who knows what that is. And that's usually a functional medicine provider or a bioidentical hormone replacement therapy certified practice. And there's a few different certifying bodies. My practice goes through BioT. There's a few other ones out there that also certify providers in how to do bioidentical HRT. So going to a certified practice would be a good place to start. And then making sure that that practice is also functional medicine based. And then knowing that there's not enough information on that annual panel. I'll give you one example, and you mentioned it was thyroid. So the thyroid is a gland in your neck, and it makes T4. That's all it does. Out in your body, you have to convert that into T3. That T3 has to be free to interact. I don't know if you remember chemistry, you have to have something come on and bind, and then it does another thing. So that T3 has to be free, and what it has to be free for is ferritin. So ferritin comes from iron. Women are traditionally deficient in iron because we bleed on a regular basis. So when you don't have ferritin to click into that free spot on that free T3, you cannot get the free T3 into the cell, and you're hypothyroid symptomatically. Your brain cannot tell the difference between T3, T2, and T1. So if you have enough T4 coming out of your thyroid, your TSH will be normal. But if you can't convert to T, you have symptoms of hypothyroidism. If you're low in ferritin, you have symptoms of hypothyroidism. The TSH cannot tell, is the system working? So I need a few more lines of labs, and I can check. Is your thyroid working? Is your conversion working? Is your ferritin available to pull it into the cell? Because I have women coming in all the time. Their hair is falling out. They're gaining weight right around their waistline. They're cold all the time. They can't think their way out of a cardboard box. Everything hurts and they're dying. And their doctor says, oh, look, your TSH is fine. Because they've Googled and they've said, oh my gosh, it's my thyroid. I know it's my thyroid. I check every single box. And they're constipated, all the things. They check all the boxes. They go into the doctor. They get one line, TSH, and it's normal. Have you thought about cutting carbs? What did you think? What did you think your 40s was going to look like? I mean, it's ludicrous. They come to see me. I just get a little bit more information because once again, I did not go to magic school. I have to measure. And I say, look, there's nothing wrong with your thyroid, but here is where your system is broken. Let's fix that.
And that's what you did to me. And you told me something interesting. You said, Dawn, you could literally work out for 3 hours a day and cut carbs and still not be losing weight. And I think that's so... And it was because of an underlying thyroid that was then connected to hormones, that was then connected to a low shortage of iron, which is why I was feeling so exhausted. I mean, it just was mind-boggling to me. And here my labs looked completely normal.
Well, not from mine, but from your primary care provider. Yeah.
Right.
Yeah.
Right.
And so I think everybody knows why we're drawn to Dr. Cunningham, because we want to marry her and just have her fix us all day long.
Not a doctor, nurse practitioner.
Well, I think most importantly,
sorry.
No, it's totally
there's
fine.
so many women that are feeling so defeated.
Well, here's what
for a lot of women who are feeling defeated, like go ahead.
I was just going to say the number one decade for a woman to be prescribed an antidepressant is age 45 to 55. That's perimenopause and menopause. So maybe she suddenly stopped making serotonin in her gut and her brain. Or maybe her hormones have quit and that's what we need to replace. Now, there's no way to measure gut production of serotonin, and there is a way to measure depression. It's called the Beck Depression Index. There's some other indices. So you can fill out these surveys and it'll tell you whether or not you are depressed. And these are validated tools in primary care. They're great tools. So the Beck Depression Index can actually diagnose depression very reliably, but it doesn't know why. It can't say, oh, we have a sudden collapse of serotonin production, or perhaps this is because our testosterone has fallen off, our thyroid's fallen off, and we have no vitamin D, which are all independent risk factors for depression. So I like to start with, these are the physiological pieces in the body that have quit. Let's put them back and then see if we still have the symptoms on the Beck Depression Index. Because if the problem is testosterone, or if the problem is estrogen, or if the problem is thyroid, or even vitamin D, the SSRI will not work. It won't make it any better. And antidepressants are known for causing sexual dysfunction. So we don't want to just have no more orgasms and still be depressed. That's not helping.
It's not helping our marriages. It's not helping our relationships. It's not helping the people that we are meant to be at this age.
It's also the number one decade for divorce.
Yeah. So you're not alone out there, everyone, for feeling lost.
Yes. These are all fixable
We
things.
can fix it.
They're
Measurable,
very fixable.
Yeah, I wanted to talk a little bit about the procedure that Dawn just did with the BioT pellets. I think most of us out there are a little bit hesitant. I know I am a little more scared than she was. She's like, let's do it. So I'm going to come in to get mine when we can reschedule it after your Forks Festival. But talk to us a little bit about these pellets. They're plant-based, bioidentical, time release. Give us the down low.
So pellet-based hormone replacement therapy started in the 1930s. So these are not new. And they were started for women who had radical hysterectomies with oophorectomies. So that's the uterus and the ovaries are gone. So testosterone, by the way, in this pellet format was first for women, not men. So that's just a little fun fact. So hormone replacement therapy is getting hormones back in the body. This is for men. This is for women. You can do creams. You can do pills. You can do patches. You can do troches, which is a dissolvable film that goes in the mouth, kind of like an under the tongue. And you can do pellets. So pellets are just compressed hormone. And the ones I use are from BioT. There are other Anazao, Carrie Boyd. There's lots of pharmacies out there that make these bioidentical hormones. And all it is Central American yam sex hormone. What's really interesting is Mother Nature doesn't use a compound once and never use it again. So human sex hormones are identical to these Central American yam hormones. So it's sustainable. There's no pregnant horsins involved. It's really lovely. I prefer pellet delivery because it's the tightest controls and it's what's called endocrine mimicry. So the procedure is we clean the hip, make a tiny little incision. The trocar goes in. It's like a surgical steel straw. And we just pop in the pellets, steri-strip, and off you go. I'm going to do that 3 times a year for women, twice a year, maybe slightly less often than that for men. So these pellets are either testosterone or estradiol. Like that's it. And a little bit of stearic acid to hold them together. It's just compressed. Stearic acid is what holds humans together. You can't be allergic to it. So what I like about endocrine mimicry, it's mimicking what your ovaries, or in men, what their testes did when they were younger. So solid organs, your thyroid's one of them as well. A solid organ like an ovary has a blood supply that goes past it, picks up hormones, and delivers that downstream. So what we want is to copy that. So when the pellets are placed, the hormones will go past the pellet, the blood supply will go past the pellet, pick up some hormone and deliver it downstream. So for your testosterone pellets, for example, you have this base dose all the time. But when your heart rate goes up because you exercise or you skied all day or you go on a big hike or you're stressed because there's a big something happening in your family or you have a new job or you're moving and your heart rate goes up or you've broken a bone and you're in pain and your heart rate goes up, now you get more hormone. And that is how a younger person can treat depression and anxiety through exercise. They're dosing themselves with testosterone every day. And that is why that stops working around the age of 35, because they don't have enough testosterone production to be able to treat their own depression and anxiety through exercise. So when you need a boost, like a runner's high, you go exercise, you get more testosterone, you get more of what you need. That's why I prefer pellets, because it is endocrine mimicry, but we can do creams. I don't like shots for testosterone. The levels go way too high and they drop right off. So to do shots correctly, you have to divide the dose, give it 3 times a week. The oil that testosterone is emulsified in often can cause site reactions, so like nodules. So that's not my favorite. So with this clinic, we predominantly do pellets, and then we have some people on creams.
Yeah. And I am going to document my entire process from start to finish, because I think there are so many women that are curious there. Aside from taking a look at individualized blood work and really that comprehensive health panel that you did with me, what would be some things that you're seeing symptomatically just by how I'm feeling and acting that might sort of lean you towards thinking that testosterone might be low? Is it fatigue? There's obviously lack of libido? What are some of the, big things that you see would be cause to get these testosterone pellets?
So for testosterone, when it's low, women experience night sweats, no libido, delayed or unobtainable orgasms. I like to say that if it's the end of the day and you're lying in bed next to the person that you love and you're thinking, I could watch TV, I could have a cookie, I could have sex, and sex is at the bottom of the list every single night, I already know you need testosterone. So that's one of my litmus tests there. Really what women see are aches and pains. It gets very ugly at the gym when total testosterone in women falls below 30 or free testosterone falls below 5. That is where the more she works out, the less fit she gets. I'm going to say that a different way. When women's testosterone, total testosterone falls below 30, she cannot build muscle. She can't. When you work out, that's breaking down muscle and then to build it back up better and stronger. If you don't have testosterone, you can't do the building back up. So every time you go to the gym, you're only breaking down. So what I see a lot in my practice is women will come in and they say, I've done all the things. I even joined this fitness program. I did this big 6-week or 12-week program where I was doing some sort of combat training or something ridiculous. And I'm sicker and fatter than when I started. And that's because the more tenacious she is and the more she's working out, the fatter she's getting faster than the couch potatoes. And that's just mean. But that's what happens when we don't have testosterone. You cannot build muscle. And when she gets tenacious, she's going to get sicker faster.
And you and I talked a lot about this. There's so much noise out there. Every teeny bopper, Instagram influencer trying to sell you supplements, gyms making money hand over fist in all of their exercise programs. And women are just grasping at every solution they can get to try to feel more like themselves. And truly, there's such a simple solution for this. And it's really just taking this comprehensive approach and using some of these modalities to help you get where you want in a more effective manner.
Yeah. So whatever you could do around age 30 should be available to you now with hormone replacement therapy. And so before menopause, that's going to be testosterone, maybe thyroid, maybe vitamin D, maybe some iron supplements, depending on what's low. And then peri and post menopause, we'll add back in the estrogen, and in women who have a uterus, the progesterone as well. So keeping your body internally age 30 means that what you do should be still available. I always say I can't lift the weights for you, but I make the weightlifting work for you.
I love that. You and I talked a lot about this too, because naturally, I think like a lot of women, I was fearful of having these pellets essentially stuck in my body for 4 months, right? What if, I didn't like them? What if I grew a full grown beard? What if, I was dry humping the seams of my jeans, and it was causing problems in my social circles or professional circles? You have a really great approach, and you left me feeling really confident. Tell me about your conservative approach and what you go throughout the process, because that made me feel so at ease.
So part of what I get that's extra in my labs is something called sex hormone binding globulin. And I do certain labs via liquid chromatography and mass spectrometry, which sounds like I'm going to be on a TV show. But basically, it's the specific molecular weight of the sex hormones. It's very exact. And when we get the blood via those assays or that way of looking at the lab, I can then tell who's going to be extra sensitive to hormones and who's going to need more. So the sex hormone binding globulin does what its name says. It binds up your testosterone, a little bit of your estrogen, but mostly the testosterone. So in a woman who has very low sex hormone binding globulin, I don't need to give her much testosterone. It's all going to be free to work. And this is where some hormone replacement therapy in years past didn't work. So someone would say, I got a regular dose, but I gained weight and I was sweating all the time and I was really hypersexual. Or women who have a very high SHBG, they said, I tried it and didn't work at all. So this lab is really a lovely way to tailor exactly what she's going to need based on, and we do the same for men, based on how much they're going to bind and how much is going to be free to work. It's just more ways of tailoring and getting this to exactly what you need, which is different from what somebody else is needing. And then I still take it down a notch, because when you're first starting any therapy, whether it's blood pressure medication or insulin for diabetics or whatever the it is, you always start at the lowest possible effective dose and work your way up if needed. We never start at the top and take it away if it's too much. That's just bad medicine. So I'm very conservative. My practice is very conservative. And we go really off of that sex hormone binding globulin because that tells us so much about how she or even he is going to respond. And so we can really start off with a much more laser focused on that patient. And then we go very slowly. The symptoms of too much estrogen, for example, is breast tenderness. Postmenopausal women can get a little bit of bleeding. The good part about menopause is no tampons. So we don't want to take that away. And then For too much testosterone, if it goes way, way, way too high, we can see weight gain, we can see facial hair, and we can see acne, and maybe even hair thinning on top of the head. Typically, the doses that we are giving can't get women to those side effects. Those are just really high doses that we don't give in my clinic. And most people who do HRT are dialing it down and they're getting better at it. More is not always better. So we want to be conservative. And so I always start very conservatively. Now we got to talk about facial hair though. Women make facial hair when they hit age 50, give or take a year or two. It happens in families. Everybody has a mom, an aunt, an older sister, a grandma who's got mustache hair, maybe a little chin hair, and some cat whiskers hanging down the bottom, and they're not on hormone replacement therapy. So my mom has waved hip, so I can talk about her. So she's on hormone replacement therapy. She's got just a couple of little hairs that she deals with. Her two sisters are not on hormone replacement therapy. They have the exact same hair. So that's clearly just what their DNA does. I was on testosterone for over 7 years before I went through menopause. I didn't have a single chin hair or mustache hair until I went through menopause. It was never the testosterone. It was the menopause. So many women are programmed to make facial hair when they go through menopause. I can't change that. And it's not the testosterone that does it. That's sort of a misnomer.
Thank you for sharing that. I'll never forget something that is a core memory of mine. I was sitting in the car with my mom and I was making fun of her for wearing an 80s jumpsuit and having chin hair. And she started bawling. And I was so surprised because I didn't mean to hurt her feelings. And we typically were joking around. And now in hindsight, looking back, she probably was going through menopause or perimenopausal or something. And for all of us nasty teenagers out there, Mom, I'm sorry. Now, getting into the good stuff, Kimberly, one of the big things about testosterone, and reputation precedes itself, is that, your libido will go through the roof. In fact, I just posted our first video this morning, and I think I got like 6 or 7 text messages saying, tell your husband to watch out. Oh my gosh, you're going to be so horny. You're going to do all of these things. I was joking with some friends last night saying, if you see me in a couple weeks and I'm limping, just know that my libido has really increased. And I might have a full grown beard, and look like Mary Kate and Ashley Olsen because I'm having so much sex and all this, stuff is helping my weight loss. But talk to us about how libido is impacted. I know you have a fabulous little sculpture of a vagina back behind you, but walk us through that a little bit, because I think that is something that's going to save a lot of marriages.
So we know in men that when testosterone falls, they get erectile dysfunction. So we know that the penis is erectile tissue. The way that erectile tissue works is the vascular bed, the blood flows in, and then there's a sphincter to prevent the blood from coming back out. And so that tissue can become engorged and become erect and become more sensitive and achieve orgasm. We know this works in men. We also know this works in women. So we know that when testosterone falls in men, they have erectile dysfunction. You want to give them back their testosterone and work on the blood flow issues. The clitoris, which I have here, is the vulva model, and here is the clitoris. So for folks that are watching, this is what your clitoris looks like. Isn't she cute? So cute. So the glans clitoris right here, if you see in the model, is this part right here. That's where everybody puts the vibrator. Right here. So the glans clitoris is only part. We also have the bulbs and the legs, and these go around the vaginal opening. This is erectile tissue, just like a penis. So when women lose testosterone, we lose the ability to get clitoral erections. That is how we have orgasms, just like the men. We still cannot get erectile dysfunction recognized in women. This is the exact same tissue as the penis. It's just in a different configuration for women. So we need vascular health. We need innervation, and all of that happens with testosterone. So for this organ to become erect during sexual activity by yourself with somebody else, we need testosterone. So testosterone is going to allow this to become engorged with blood, allow the bulbs to have fluid, which, by the way, female ejaculation.
And that's when the magic happens. Gosh, yeah. Kimberly, you are brilliant. You are beautiful. You are bold. You are all of the things. We want to have more of you on the Hot Flash Health podcast because you are a wealth of information. But we also want other women to feel seen the way that you made me feel seen, and to help them have optimism that life is not over. It's just beginning. So How can we find more of you? Share with our listeners how they can find you. You're an author, you've got books, you've got an office, you've got all of the things. Tell us how we can get more of you in our lives. Well, and stay tuned, Hot Flashers, because I am going to document my entire process in getting these testosterone pellets and what Kimberly has shared with me in my blood work. But like I've said time and time again, I was in tears in your office because you were the person that made me feel seen. And I can't thank you enough for that. My mom always says, live with a heart full of gratitude. And for today and moving forth, I am so grateful for you. So that's a wrap, Hot Flashers. We are here to give you the real scoop on midlife wellness. We're just real women who don't want any fluff. We don't want to cross our fingers. We just want real answers for thriving through menopause. If you haven't already, check out our 2-minute menopause score on our website, www.hotflash.com. Grab an at-home hormone test so you can be validated and take it into experts like Kimberly Cunningham and see what's really going on in your body. No more guessing games. This is a roadmap, ladies, to owning your queenager status. And please, please, please help us keep this revolution going. Follow us on Instagram, Facebook, YouTube, iTunes, subscribe, share with your gals, and let's get real about menopause everywhere it needs to be. So for today, thank you, Miss Kimberly Cunningham. We promise there will be more of you. And ladies, go in there and see her. Talk to you soon. Thank you.
And that's a wrap on today's episode. Remember, menopause may be a wild ride, but together we've got this.
And don't forget to follow us on Instagram, Facebook, TikTok at Hot Flash Health.
Stream and subscribe to us on any of your favorite listening platforms like YouTube, Apple, and Spotify.
And of course, share your thoughts with us. We love hearing from our amazing listeners.
And until next time, stay sassy, stay fabulous, and keep those hot flashes in check.
Yeah, girl.
Woo!